I want to sincerely thank all of you for joining the teachings this morning. So, this weekend we shall be focusing on endocrinology. And endocrinology is, well, it depends on how you see it. I see it as an area that is not too big, but quite a lot of people see it as a big area. Maybe because quite a lot of questions come from endocrinology. Maybe because some topics in endocrinology could be a bit technical. But if you see it from my angle, you see endocrinology as an easy subspecialty, as an enjoyable one, and one that you can play around with very easily. This morning, I would like to enjoin all of you to it's less than 2 months to the AKT. I want to enjoin all of you to start active reading, active studying, and study with purpose. Some people focus on the slides and miss the matter. They miss the real deal. They miss the meat in the food. So I told Admin thank you. I phoned the IT team. I wrote up 6 new slides. I said, can you prepare these 6 slides for me? I'm going to teach with just 6 slides. In a similar fashion, what I'm begging you guys this morning is to streamline your reading. Well, there's if you open endocrinology, there are several topics. There are rare topics. There are big topics. Their topics are everywhere. But you've got just 2 months. This is not the time to be going around and learning specialist procedures in endocrinology. That is counterproductive, my friends. This is not the time to sit down on one topic in 3 days. You want to understand one topic in 5 days. That is the reason of the course. So that you can understand that topic that you want to take 3 days to study, you can understand it in 5 minutes. So I want to beg you to be streamlined. Anytime you see an article, a note, a topic, 5 pages, please, that's not when to sit down and start to study 5 pages or 8 pages of a topic. Leave it. You are not training to become an endocrinologist, my friends. So this morning, I want to challenge you to be streamlined. I want to challenge you to be targeted. I want to tell you your exam is almost here. And if you have been resting, that's fine. If you've been going to parties, that's okay. If you've been facing family things, that's fine. But this is the time to abandon everything and give it your shot. Just about 1.5 months to go. This is the time to do the real work. Anything that you've not done before now, you've done before now, that's good. But this is the time to start, the beginning of September. So I thought I'll start with that. I always want to challenge you because sometimes the AKT is the right mindset. Passing the AKT with 90 and passing the AKT with 70, the difference is the right mindset. Some people go in with the mindset that, well, I just want to pass. So if I pass, that's okay. They end up getting 71.5. That's risky, my friends. You're lucky this time because the cutoff was 71. How about if they've made it 72? That's dangerous. But some other people go in with the mindset that I'm going to scatter the AKT. That is the right mindset, my friend. And this is what EasyLearn promotes. To scatter the AKT. Someone says, I'm going to deal with the AKT. Someone says, I'm going to put the AKT on his knees. That is the correct mindset. If you want to do that, you need to be targeted because there's just too much to study. And so this morning, I'm going to teach you how to be streamlined, not for endocrinology, but for all courses, using endocrinology as a case study. Again, before I just go into endocrinology, if you give me 1 I'm just going to talk about your progress assessment. Someone was asking me about the progress assessment. We call it a progress report. I mean, this is the only course in the UK that gives you a progress report, and we'll give you a minimum of at least 3. We'll try and give you 5 in this cohort, but I'm saying every cohort you get a minimum of 3 progress reports sent to your email. So far, you attempt our mocks. Now, the progress report is not just based on the mock, but the mock is a great influencer of the report we give to you. It tells you your preparedness level. And we are sure that a progress report a week to the AKT is useless. And so what have we done? I'll tell you what we've done. What we've simply done is to start your mocks early, to start to challenge you early, to start to test you early, to see whether you are moving on the right trajectory or not. This is very helpful to candidates. For candidates that are not sitting up, it helps them to sit up. So for candidates that need to stand up, it helps them to stand up. And so the reason why I'm bringing this up is that the progress report should not make anyone feel down. It should not make anyone, many candidates, not some, I wanted to say some, but many candidates have called me and said, Dr. Ola, should I attempt the AKT in October? My answer is always the same. The answer is yes. If you move it forward, one of the things is that you are moving your forward. If you move it forward, you become lazy again for this October AKT, so you don't end up writing the AKT. What you need to do is face your problem squarely. Your problem is surmounting the AKT. Surmounting the AKT is easy with systems and proper techniques, my friends. And so one of the systems that we've put in place to ensure that you don't get anything less than a 90 is the mocks. The mocks are meant to be difficult on the first few attempts. But as you go on, as you get into October, the mocks are supposed to be easier. What does that mean? It means that you are getting better. It means that you are progressing. It means that you will pass the AKT. That's simply what it means, my friends. And let me just say this about the mocks. The mocks are not just to test you and to get a progress report about you. The mocks are for us to teach. For example, if we give you 100 mocks next week, we are going to be teaching 100 topics next week. This is how the mock works. So your session 2 and part of your session 1 will be replaced by review, but it is not review of the answer. We will not tell you, okay, question 1, okay, your answer is A. We've already done that. We'll send your emails, and we'll send the answers to your emails. You get that. It is to teach a proper topic. So, for example, if question 1 was on thyroid, we will be teaching thyroid disease. So they are also what we call teaching mocks. So it's a win-win situation. They help you to challenge yourself. They help you to know what is important, but they help us to teach as well. Teach topics that are of importance, because every single mock question has been specially crafted by GPs. They've sat down, they've looked at it, they've seen the high yield areas, they've seen the areas on the RCGP website where RCGP says candidates have not been doing well, and this is where the mocks have come from. So with this, I don't believe anybody should get less than 90 in the AKT. It will be hard for me to fathom that someone will actually do all these mocks, this number of mocks, and still get less than 90. I will be surprised, my friends. I'll be shocked, my friends. So, having said that, AKT is not a child's play. I've said it can be easy. I've said it can be difficult. It depends on how you attack it. So, I often describe the exam as an exam that is for adults, not for children. So, it's not an exam you say, let me try. It's too expensive to be saying, let me try. Some candidates say, let me just try once. Why don't you just pass it? What is let me try? So someone called me and said, well, because this is my first attempt in ST2, I just want to use it to try. I'm like, what's that? Please, and please, if you have the mindset of let me try, it's a waste of money. Why try when you're in the Easy Learn program when you can pass? So please, and please, don't try the AKT, pass the AKT. So over 50% of the questions in your mock will have already been covered in a way. And if they all look new to some of you, that means there are a few problems there. If you are looking at the AKT mock questions and they are looking distant, they are looking like things you've never seen, they are looking like things you do not understand, there is a problem, my friends. And I'll tell you, it can be any of the 4 or 5 problems I'm about to list. Some candidates are in class and they are enjoying the class. but they are not absorbing the content. It can be that problem. And that's why I have taken quite a lot of things away from the screen. I've made the screen very simple so that you don't have distractions from my side. Some candidates, the problem is they are distracted. They are here, but they are not here. If you are that candidate, you know what is distracting you. You need to pull it out in September. I mean, it was okay to have it in August. If it was children walking around, you need to go to a quiet room, my friends. If it was your locums, you need to stop it now. If it's anything, you need to sit down and rearrange the timetable, because this is the time. This is the golden month, September. So I want to beg you, if there's a distraction, you know it, remove it. Keep it aside. After you pass the AKT, you can put as many distractions in your life as you want. The third set of people have problems with interpretation. So I call it interpretation problem. What does that mean? They have the everything at their fingertips. If you ask them what are the vaccines that are free on the NHS, they spit it out. Which vaccines are live vaccines? Before you finish talking, they tell you. What are the cancers related to HMPCC? They can tell you that. What are the commonest cancers in males and females in the UK? They spill it out. But when you finally give them a question, they cannot get the answer to the question. That is interpretation problem. This is where the mock comes in. By the time you see close to 1,000, it will be over 1,000 questions. By the time you do over 1,000 questions in mock, there's no way you can have interpretation problems. Again, this is why I beg you. We found out that the teachings are good, but the teachings are only 15% of the 100% that makes you pass the AKT. If you are missing the drill, you are missing the main deal. If you are missing the drill, you are missing the nutrition in the food. Then some people now miss the drill and miss the mock. How will you not struggle? Because teaching alone cannot help you. So the mock helps with interpretation of questions. The mock helps you to see how the question will come. The mock helps you with timekeeping. It helps you to be fit. It's like an athlete. The exercises you do, the practice you do helps you to be fit. The mock is the practice. So how do you miss the practice and you want to win the Olympics? It's not possible, my friends. So can I challenge you to take the mock very seriously and attempt all mocks? So for those who have interpretation problems, hopefully after doing 1,000 questions, interpreting 1,000 questions, and seeing how it was interpreted on our own side, you can't fail questions in the AKT. How do you fail them? That's the question. The other thing is, some people are not planning to write the AKT. So it's not everyone here that is planning to write the AKT. If some people here are in ST1, which is good. I mean, I've put everyone on the same group just because all of you are GP trainees. If you don't write the AKT this year, you write it next year. Next year is not far off. So if you're an ST1, you're still, oh, it's still far away. I've still got time. You're a joker, my friend. Because before you know, e-portfolio will stop you from studying. Before you know, A&E won't allow you to study. Some of your postings won't allow you to study. Why not become serious now and use the time now? So some people are saying, well, I've still got like 6 months. So I say, no, start now. Behave as if your exam is in October. And this is why I challenge everyone. Your exam has to be in October for you to become good. The exam is not just, this is not just about the exam. It's about you becoming. How do you practice what you are practicing there with confidence when you are not sure of what you're doing? So the teachings help a lot to ensure that you are also doing well as a GP trainee. So that's the fourth one. Some people need a push. Please, if you have identified yourself as a push, please join the Pass Plus or Pass Guarantee group. As time goes on, the Pass Plus or Pass Guarantee group is getting hotter. With them learning 2 or 3 things in the last class, they will see that they've learned almost 18 things in one day, and they are repeating it. And they have to repeat it. They have to know it. And we are adding and adding. So if you are in a situation where you need a bit more push, you need to be in that pass guarantee or pass plus. Contact admin and discuss that with them. So let's move on to endocrinology today. I just thought I should challenge you because sometimes you have this information at your fingertips. It's not about the information at your fingertips, it's about how you utilize them, my friends. So I just thought I should challenge you to utilize them properly. We're going to start the program. My name is Olale Kogugbemi, and I'll be taking you this endocrinology program. So endocrinology has been divided into two. Endocrinology is a large area. By the time I got the total number of points, I discovered that there were 500 points you need to know before stepping your leg into the exam. That's what we call the point system. That's the only way we are able to measure that you are ready for the exam. If we ask you out of 500 points, you give us 400 points, we tell you to go to the exam. If you give us 450 points, we tell you give us a 90. If you manage to give us 500 points, we tell you that the RCGP will recognize you. However, that's all the points that they can ask you in the exam concerning endocrinology. It can't be more than that. So when I looked at the 500 points, I decided that how do I do this? The 500 points are just maximum of 12 topics, my friends. One of the 500 points, well, a couple of the 500 points are Addison's disease. Another group of the 500 points are Cushing's disease. Another large group of the 500 points is Crohn's disease, my friends. Hyperparathyroidism is a huge question in your AKT. Well, if you want to go to the AKT and you have not studied thyroid disease, I don't know what you are doing. And so what I've done today is I'm just going to be taking Addison's, Cushing's, Crohn's, hyperthyroidism, and thyroid disease. Tomorrow we'll do endocrine 2. Please, acromegaly comes out in your exams. If you don't know pheochromocytoma, we'll know a bit about it in tomorrow's class. There are syndromes in the AKT that fall under endocrinology, and you need to know them. What syndromes am I talking about? Liddle's disease, my friends. Bartter's. There's something called Gilterman's. What's the difference between Liddle's disease, Bartter's, and Gilterman's? All of them have got hypokalemia, but only Liddle's disease have got hypertension. You need to be slick. You need to leave out jargons, my friends. Okay, what other syndrome can you see in the AKT? Men's syndrome. Have you forgotten that metabolic syndrome is under endocrinology? So syndromes in endocrinology, we're going to deal with them tomorrow alongside pheochromocytoma and acromegaly. Of course, endocrine pharmacology is a big one. I will spend time on steroids. You need to know the 360 degrees of steroids. If they want to pull you, you push them. If they want to run into the sea, you follow them. If they want to take it dirty, you make it dirty for them as well. You are ready. That's what we call a gallant AKT candidate. You are ready to pass the exam. We'll look at every point they can want to ask you concerning steroids, my friends. Well, the big one for today is thyroid disease, but the big one for tomorrow is diabetes. How do you not know Modi? How do you call yourself a trainee and you don't know about pre-diabetes? It's wrong, my friends. Well, I presume that you should know about type 1 and type 2 by now, but you need to be slick when it comes to type 2 management. We have talked about the management of type 2 over and over again. I'm going to be talking about it fully tomorrow. So tomorrow the big one is diabetes. Today the big one is thyroid. The smaller ones are Addison's, Cushing's, Crohn's, hyperparathyroidism. Tomorrow the smaller ones are acromegaly, pheochromocytoma, syndrome in endocrinology, and endocrine pharmacology. Please be good. Okay, without wasting more time, let's talk about Addison's disease. My friends, in the AKT, Addison's disease can come in different forms. And the form it comes in helps you a lot, because if you have a picture of Addison's disease in your mind, then you will do very well. If you don't have a picture, you will struggle. So what does Addison's disease mean, first of all? My friends, Addison's disease is too little cortisol. When there's too little cortisol, think Addison's. And there are a lot of things that can be responsible. So we'll talk about Addison's, which is primary adrenal insufficiency, but I'll link you into what we call secondary adrenal insufficiency. I'll broaden your mind, my friends. So, how would a patient that is feeling tired all the time? By the way, tired all the time is a top AKT question. So a patient that is feeling tired all the time, this causes weakness with the GP. A patient that has got anorexia, weight loss, please think Addison's. Well, the clincher on your question will be the pigmentation. Addison is a unique condition that has got both hyper and hypopigmentation. Don't fail it in the exam, my friends. Can I just challenge you? You need to know all the causes of hyperpigmentation in the AKT and hypopigmentation. So by the time I say hypopigmentation, the first thing that should drop into everyone's mind is vitiligo. Vitiligo, think hypopigmentation. Vitiligo, think Addison's. Treatment for vitiligo, think tacrolimus. Think camouflage. Think steroids. So vitiligo can grease you in your exam, but know that vitiligo can be a part of another condition. So sometimes in the exam, the question can be on vitiligo under dermatology. Other times in the exam, the question can be vitiligo as a part of another condition like Addison's. So hyperthyroidism, you will see spots, hyperpigmented spots on the patient's body. Once you start to see that weakness, tired all the time, you are seeing hypoglycemia. The patient is complaining of hypotension. What are you thinking? That is a picture of Addison's, my friends. Well, whenever we're talking about Addison's, Cohn's, and Cushing's, please know the double H. I call them the H brothers. What does that mean? You need to know the difference, which one is which one is kalemia, and which one is tension. So, Addison's, to remember, Addison's adds potassium. It takes away blood pressure. So, Addison's causes hyperkalemia, adds potassium, and Addison's causes hypotension. It brings down the BP. In Cushing's, which is the opposite of Addison's, the opposite happens. Cushing's will bring down potassium, hypokalemia, but we add on blood pressure, hypertension. Now, Cushing's and Cohn's are similar. They have the same picture biochemically. When you check the blood pressure, they've got the same picture, but what differentiates them is the story. And we're going to come to that shortly. I don't want any of you to fail this in the AKT, so let me just go slowly with Addison's. Addison's picture in the AKT is hypo or hyperpigmentation in a patient with anorexia, the patient that is salt craving, a patient that is losing weight, a patient that is tired all the time, a patient that has got hyponatremia or hyperkalemia, or a patient even in shock. They can have Addison's. Now, in Addison's disease, I just want to make it clear, there are only two hypers. Every other thing is a hypo. There's hypoglycemia, there's hypotension, there's hyponatremia, there's hypopigmentation. The hypers are hyperpigmentation and hyperkalemia. Everything is a hypo. How do you feel it now that I brought this picture? You see, some candidates, the problem is they cannot interpret this picture. They've read it, but they cannot interpret it. Someone will be waiting for them to write hypopigmented lesions. They won't write it. They will say he has past medical history of vitiligo. You will not ever see that he's got hypopigmented lesions. How do you feel it? Well, another candidate will be expecting them to write that this patient has got hypotension. They will never write it. They will write blood pressure 86/51. That's what they would write. And if you do not know the normal level of potassium, that is 3.5 to 5, what are you doing in this class? Why do you want to write the AKT in October? Because you have to have common biochemical reference ranges at your fingertips. I said that when we're doing women's health. I told you normal estradiol. I told you normal creatinine, 50 to 120. We talked about the normal prolactin, 50 to 450. You must know FSH, LH, 2 to 20, my friends. Testosterone in females is different from testosterone testosterone in males. You must have this at your fingertips. Otherwise, how do you want to answer the question on hormonal profile? You can't answer it, my friends. The same thing in the light of endocrinology, you have to have all the biochemical reference ranges at your fingertips. Urea 2 to 7, my friend. Potassium 3.5 to 5. These things, they shouldn't be far away from you. You should know normal sodium 135 to 145. You should sing them regularly. They should be things that are part of you already. Because if you start to do that drop down in the AKT, you're wasting 10 seconds. So, my friends, now that you know how the question will come, what we've seen the picture, what is primary insufficiency? Well, that is Addison's disease, and that's what we are talking about today. If you check the picture, in addition to the picture I've just given you, the question will say there is low cortisol, but ACTH will remain normal. See that? You now know that this problem is local. This problem is from the adrenal gland. Let me give you that picture again. Low cortisol, normal ACTH is primary adrenal insufficiency, what we call Addison's disease. Whenever you see that the cortisol is low or the ACTH is high, you know that this problem is from a higher center. It is secondary adrenal insufficiency. How do you feel it? My friends, I want to beg you not to fail any question in endocrine. Endocrine is easy. Secondary brain problem. Secondary adrenal gland. Primary, the adrenal gland is the problem. Addison's, low cortisol. Adrenal insufficiency, low cortisol. Anytime you see adrenal insufficiency, they are talking about low cortisol. What you now need to do is check ACTH. Is ACTH normal? Is a problem from the adrenal gland. ACTH high is probably a problem from a secondary center. Adrenal insufficiency, secondary adrenal insufficiency. So let me paint that picture again for you. Addison's biochemical picture will be low cortisol, low aldosterone, low BP, low sodium. The only thing that is high is potassium. How do you feel it? Do you know I've just gone around to just tell you the same thing over and over again so that you don't feel it? I'm just telling you that the only thing that is high biochemically is the potassium. So in the AKT, they give you a lengthy question. Under the question, they want to give you headache. They now start to give you biochemical readings. Just check, is there cortisol there? Yes. Is it low? Tick. We are dealing with adrenal insufficiency. Is there aldosterone there? Is it low? Tick. We are dealing with adrenal. Is there blood pressure there? Yes. Tick. Is it low? Yes. We are dealing with probably Addison's disease. Is sodium there? Yes. Tick. Is it low? We are dealing with adrenal insufficiency. Is potassium there? Yes. Tick. Is it high? You've got your answer. That's Addison's disease, my friends, in the AKT. That's adrenal insufficiency in the AKT. The only other thing we now need to look for in the question is ACTH. So you scan quickly, where's ACTH? Where's ACTH? Oh, that's ACTH. Is it normal? Addison's. Is it high? Secondary adrenal insufficiency. How do you feel this question? This is the clincher system. This is how you should approach it. This is why we say you can actually answer a question in 10 seconds. Some people go, it's like you go to someone's house. They say, go and look for Mrs. B. You get there, you have forgotten who you are looking for. You knock on the door. You say, I'm looking for one woman. They say there are 10 women here. Well, how do you now solve that problem? Because Mrs. B is one of the 10 women you are looking for, but you've forgotten Mrs. B's name. So you can't find Mrs. B, my friends. The only way you can do it is to have clinchers and cliches at your fingertips, and you should be able to appreciate and use them in the AKT. So this is how it goes, my friends. So you've got a picture. I won't dwell too much on pictures. In the AKT, I'll try this morning not to explain in full details the test, but if you join us in the drills in full details, you'll be able to understand anything about tests in these endocrinology topics. Now, the questions they can ask you can border around what do you do in primary care. So Addison's in primary care, my friends, is 9 a.m. cortisol. Addison's in secondary care is short synactin test. How do you feel it now that I've told you? Primary care, that's your GP practice, do cortisol at 9 a.m. Secondary care hospital is SST, short synactin test. Please, people usually mix up DST with SST. Don't ever do that. SST is to Addison's as DST is to Cushing's. SST is to secondary care Addison's as DST, which is dexamethasone suppression test, is to secondary care Cushing's. 9 a.m. cortisol is to primary care Addison's as 24-hour urinary cortisol is to primary care Cushing's. Look at how things have become easy for you. Don't fail it in the exam, please. Well, what is short synaptic? Yeah, I'll say it again so someone hasn't heard that clearly. 9 a.m. cortisol, primary care Addison's. Short synaptic test, secondary care Addison's. 24-hour urinary cortisol, primary care Cushing's. Dexamethasone suppression test, secondary care Cushing's. It will come out in October AKT. How do I know? I'm not a magician, my friends, but candidates have been failing it. It's on the RCGP website. This particular point I've just said, you will see it in your exam. Trust me. I was telling the previous candidate, you may see this kind of question in your exam. They came and said, did you see the question? I said, no. It's on the RCGP website. These questions you say will come out in our exam. They came out in our exam word for word. I say it's on the RCGP website. RCGP has given you a clue. They are telling you that we want to test. They are giving you the answer already. They say we want to test you again on this day. Can you go and read it? That's what RCGP are saying. How do you then fail it when RCGP has told you where the questions will come from? Well, my friends, that's how to know the investigations of Addison's and Cushing's. That's how to differentiate it. But I was about to just talk a bit about short synaptic tests. Sometimes I say I won't do something, then I become handicapped. I find it difficult to move on without talking about it. My conscience pricks me, my friends. This is how your conscience should prick you when you don't know a topic. Someone asks you, well, do you know a bit about Crohn's disease? Don't say I'll read it later. Your conscience should disturb you. That time is the only time that you have to study Crohn's disease. Study it, my friends. Don't allow it to go. Hold it down. Tell Crohn's disease that today is me and you. This is how to study. This is how to become good, my friends. So, well, short synaptic test, what you need to do is to do your 9 a.m. cortisol. That's at 9 a.m. Do another one, what we call, so you give the patient what we call synactin. An artificial cortisol. You give them and check at 30 minutes and check at 60 minutes. So what do I mean? Short synaptic test is cortisol level at 0, cortisol minutes, and cortisol level at 60 minutes. 0, 30, 1 hour. How do you fail it? The picture is that your 0 should double when you give synactin. If it has not doubled, if it is less than double of what 0 was, you're dealing with Addison's, my friends. So normally it will double. Let's say you have 200 and you give synactin, it should be at least more than 400. If it's not moving more than 400, you've got your answer. You are likely dealing with Addison's. Some books will say generally the rule of thumb less than 200 for some books and some school of thought, they will say it's already Addison's. As for your 9 a.m. cortisol, as they say, if it's less than 600, you are likely dealing with Addison's disease, my friends. How do you feel these things? Okay, so now in the AKT, they will give you a lengthy question and they will tell you that the patient has got neck stiffness. He's got projectile vomiting. He is salt craving. Some candidates will now be saying, well, if he's got projectile vomiting, neck stiffness, that is meningitis. My friend, that's a type of, is a cause of Addison's. They are talking about Addison's. What's that? Addison's can be caused by meningococcal septicemia, what we call Waterhouse-Friderichsen syndrome. It can come out in your AKT. So, meningococcal septicemia is a cause of Addison's. Don't fail it in the exam. Well, I give you another picture, my friend. It's a picture of a 54-year-old guy with weight loss and Addison's symptoms. Someone is still trying to think. That's bronchial carcinoma, my friends. Bronchial carcinoma is a cause of Addison's disease. Well, let me tell you about this 36-year-old woman who has been having recurrent miscarriages and she's having hyperpigmentation. If you spend more than 50 seconds answering that question, you have harmed yourself. If you spend more than 30 seconds answering that question, you've made all of us an easy learn, the whole family of easy learn. You've made us sad, my friend. That is antiphospholipid syndrome causing Addison's. How do you fail it? Recurrent miscarriage is the clincher for antiphospholipid syndrome. Now they've added hyperpigmentation. It's Addison's. If they add salt craving, it's Addison's. Okay, I give you this picture of a patient with potassium high, hyperkalemia, sodium low, hyponatremia, blood pressure low, hypotension, and they say at the end of the question, they say the patient's recent result shows low CD4 count. HIV causes Addison's, my friends. Low CD4 count with a picture of Addison's, think HIV-induced Addison's disease. Well, I can give you another question in the AKT. Is a 51-year-old female with fever, night sweat, cough, and decreased cortisol. How do you not know that is TB? Tuberculosis is a cause of Addison's. If you are in this class and you are still not convinced that the commonest cause of Addison's is autoimmune, I'm telling you now, it is autoimmune. It is not TB, my friends. It's not antiphospholipid syndrome. It's not cancer. It's not meningococcal septicemia. It is autoimmune causes. That is the commonest cause of Addison's. That's why Addison's is friends with vitiligo. That's why Addison's is friends with type 1 DM. That's why Addison's is friends with celiac disease. That's why Addison's is friends with other autoimmune disease. By the way, I just remembered I asked a candidate about acanthosis nigricans. Please, acanthosis nigricans is not associated with type 1. It's associated with type 2. Don't fail the question in the exam. So it is not autoimmune. That's what I'm trying to say. Know the autoimmune friends, my friends. Great. Hashimoto's, you need to know them. And you need to be good, my friends. You click as you're good. So 3 things: be quick, be smart, be fast. If you are fast, that means you can quickly scan and get what the question is talking about. Slickness is your ability to use clinchers and cliches to answer your question. That's what makes you good, my friends. Well, still on Addison's, in the exam, they can decide to run dirty. They can start to take you to the management. They leave the picture because they know you've gotten it. They leave the investigation. They know that candidates now are passing it. They know it's in primary care, it's 9 a.m. cortisol. In secondary care, it's shots in acting test. So what do? They take you into the management. They say, let's know whether this candidate can answer. Well, it is glucocorticoids and mineralocorticoid replacement. That's all. It's not hard, my friends. Glucocorticoid, mineralocorticoid replacement, that is the treatment for Addison's disease. So, Addison's disease, you need to give hydrocort. How do you give it? That's the question in the AKT. So, some candidates know that you give mineralocorticoid and glucocorticoid, and that's all they studied for the exam. They will fail the question. Why did I say so? You need to know how hydrocort is given in the exam. So how do you give hydrocort in the exam? You have to give at least 2 to 3 divided doses a day. So this is how the question will come. I'll tell you. They say, well, a patient has got hydrocortisone and has a total of 30 milligrams. How do you give it? First of all, you have to give majority of the dose of the hydrocortisone in the first half of the day and minority in the other half of the day. So let's use 20 milligrams as example. If the patient has got 20 milligrams hydrocortisone to be administered daily, how do you give it? 15 before 2 o'clock or 15 before in the first half of the day and 5 in the other half of the day. That's how it goes. Again, it has to be 2 divided doses. So you can do 15 in the morning, 5 in the evening. Or you can do 10 in the morning, 5 in the afternoon, 5 in the evening, 3 divided doses. So what they will do in the AKT is give 20 milligram once a day. That candidate has failed it because you cannot give everything once a day. You have to divide it into 2 or 3 divided doses and give majority half of the day. That's how it works, my friends. So I don't see candidates failing this. With the fludrocortisone is a fixed dose. Well, in the AKT, let me tell you, they can bring a picture of what we call Addison's crisis. You need to know a patient in crisis. The patient will be very unwell, my friends. That patient needs to go to A&E. What are you doing treating Addison's crisis in the GP practice? GMC will knock on your door if you do that. Don't do it. Is counterproductive. It's not fair on yourself. I mean, you are just becoming a new GP. You are attempting to treat Addison's crisis in the primary care. Don't do that. Is not good. That's not the right thing to do, my friends. So Addison's crisis, you need to do immediate management. Give fluids, my friends, in the A&E. So why you are referring is because you cannot give IV fluids in the primary care. Why you are referring is because you cannot give IV glucose, what we call dextrose containing fluid. Why you are referring is because there is no IV dexamethasone in your tray. These are some of the things you need to be giving this patient to calm them down. So if you see a patient, a picture of Addison's disease in crisis, refer to hospital for IV fluids, refer to hospital for glucose, refer to hospital for IV dexamethasone. You can't fail the question. I just thought I should mention that that's not one of the things I plan to talk about today. I'll just move on to sick day rules, my friends. Sick day rules, you need to know the sick day rules of Addison's disease. There's sick day rules of diabetes. There's sick day rules. And if you've not been listening to me in these whole teachings, I've taught the sick day rules of diabetes a couple of times. The one I've not really mentioned, apart from people in Past Plus that have heard it, is the sick day rules for Addison's, my friends. So how does it work, my friends? Sick day rules for Addison's, it depends on the scenario you have been painted with. Well, you see a patient who has Addison's and the patient has severe nausea. Please, if you choose the answer for severe nausea for vomiting, you failed in the AKT. They are far apart. Severe nausea, give 20 milligrams hydrocort orally with what we call ORS, that's oral rehydration salt. Give them to be sipping it. Let me repeat that again. Severe nausea with Addison's, 20 milligrams hydrocort orally plus ORS. It will come out in your exam. Trust me. Well, you've seen another patient. This patient has fever. No nausea, no vomiting, just fever. What you need to do is to double the dose of their hydrocort. So if they were on 20 milligrams, give 40 milligrams. How is that difficult? Well, you've seen another patient who has had an injury, or it can be a patient in shock, and they are known to have Addison's. Major injury, I mean a very big injury that has caused a bit of bleeding. What do? Give 20 milligram hydrocort orally. This is where candidates fail it. They always think the hydrocort is IM and the AKT helps them. What does the AKT do? The AKT can paint a question of 20 milligrams hydrocort IM. That is usually that's a likely answer in the AKT. 20 milligrams hydrocort IM. If you choose it, you failed it. It's orally, my friends. Orally, my friends. The only place where we have IM is when there's Addison's disease and it makes sense to you. The patient cannot take orally, so you need to give via another route. But my friends, Addison's and vomiting in the AKT is emergency. Addison's and vomiting equal to emergency. Someone has not heard it very clearly. If a patient has Addison's and they are vomiting, when they phone the 999 number, what they tell them is, paramedic, I want to declare an emergency. I'm known to have Addison's disease and I am vomiting. The ambulance will race there in less than 5 minutes. If they need to send a helicopter there because the patient is in a countryside area where the ambulance cannot easily get to, they will send a helicopter there. Addison's with vomiting is an emergency. The patient can basically die away from there. The patient can be met on the floor by the time the ambulance gets to the house. Addison's disease and vomiting is not a joke. Now, let me tell you a story. If a patient has called you in the GP practice and says, Doctor, I've got vomiting, and you check on the patient's page, the patient has Addison's, drop the call, phone the ambulance, tell the ambulance, I've got a patient, Addison's disease, vomiting, this is the address. you need to go there now. That's how serious Addison's disease is. So what do you do before the ambulance comes in? They need to give themselves 100 milligrams IM hydrocortisone. 100 milligrams IM hydrocortisone. Can I go over all these things again? Severe nausea, 20 milligrams hydrocort plus oral sip ORS. Major shock, 20 milligram hydrocort orally, no ORS sip. So the one that has the sip is nausea. The one that doesn't have the sip is shock or major injury. Well, if it's temperature, you've checked the temperature is 38.2, just double the dose of the hydrocort while you treat. Well, if it is vomiting, it is not your job to do. It is a job for the emergency room. Tell them to take 100 milligrams IM hydrocort, which they already know, and they should declare an emergency. I don't think, now that I've repeated it 3 times, a candidate from Easy Learn will fail it. I don't know how. I don't know why that wants to happen. But we have tried our best that if the candidate deliberately wants to fail it, we've echoed it too much that the candidate will not fail it. Please don't fail this question. So that's Addison's disease. Well, I know some of you, I've just tried to wake you up. I use the easiest ones to wake you up.